The examination of the nervous system in infants includes techniques specific to their particular age and is highly dependent on several factors. Internal factors affecting findings include alertness and timing with respect to feeding and sleeping. External factors affecting findings include the presence of parents or the presence of fearful stimuli. Primitive reflexes are present only at certain ages and then disappear. Neurologic changes often present as developmental abnormalities. For this reason, neurologic and developmental examinations often are combined. Assess the mental status of infants during alert periods. If the baby is transiently too drowsy, return at a later time. First, assess motor tone by carefully watching the infant's position at rest, and then testing resistance to passive movement. Assess tone as you move each major joint through its range of motion, noting any spasticity or flaccidity. Hold the baby in your hands to determine if the tone is normal, increased, or decreased for age. You can test for the infant's sensory function only in a limited way. Test for pain sensation by flicking the infant's palm or sole with your finger. Observe for withdrawal, arousal, and change in facial expression. Do not use a pin to test for pain. Testing an infant's cranial nerves requires special methods that differ from those used for older patients. Cranial nerve 1, which mediates sense of smell, is difficult to test in infants. Cranial nerve 2 mediates vision. Cranial nerve 2 can be tested by having the baby regard your face. Look for facial response and tracking. Cranial nerves 2 and 3 control response to light. To test, raise the baby to a sitting position to open the eyes. Use a light and test for optic blink reflex. You may also use the otoscope without a speculum to assess pupillary response. Cranial nerves 3, 4, and 6 mediate extraocular movement. These nerves can be tested by observing tracking as the infant regards your smiling face moving side to side. Use a light or a toy without sound for this test if necessary. The motor portion of cranial nerve 5 innervates the muscles of mastication, while the sensory portion mediates facial sensation and the sensory part of the corneal reflex. Cranial nerve 5 can be assessed by testing the rooting reflex and the sucking reflex. Cranial nerve 7 innervates all muscles of facial movement and expression. Cranial nerve 7 should be assessed by observing the baby crying and smiling, while you note symmetry of the face and forehead. Cranial nerve 8 mediates hearing and vestibular function. Cranial nerve 8 may be assessed by testing acoustic blink reflex and tracking in response to sound. Cranial nerves 9 and 10 mediate the sensory and motor functions of the palate, pharynx, and larynx. These nerves are assessed by observing the infant's coordination during swallowing. Cranial nerve 11 innervates the sternomastoid muscles and upper trapezius muscles. Cranial nerve 11 is assessed by observing the symmetry of the infant's shoulders. Cranial nerve 12 mediates motor functions of the tongue, affecting articulation of words. Observe coordination of swallowing, sucking, and tongue thrusting. The deep tendon reflexes are variable in newborns and infants because the corticospinal pathways are not fully developed. Thus, their exaggerated presence or their absence has little diagnostic significance unless this response is different from results of previous testing or unless extreme responses are observed. To elicit deep tendon reflexes of the biceps and quadriceps, use the same techniques as you would for an adult, substituting your index or middle fingers for the neurologic hammer. However, the triceps, brachioradialis, and abdominal reflexes are difficult to elicit before 6 months of age. Although a normal flexion plantar response is obtained in 90% of infants, a positive Babinski response to plantar stimulation that is, dorsiflexion of the big toe and fanning of the other toes, can be elicited in some normal infants until 2 years of age. The infant's developing central nervous system can be evaluated by assessing infantile automatisms, called primitive reflexes. These develop during gestation, are generally demonstrable at birth, and disappear at defined ages. A few of the more important primitive reflexes include the palmar grasp reflex. Test for this by placing your fingers into the baby's hands and pressing against the palmar surfaces. In infants up to 3 to 4 months old, the baby should flex all fingers to grasp your fingers. The rooting reflex. Stroke the perioral skin at the corners of the mouth. In infants up to 4 to 6 months old, the mouth should open and the baby should turn the head toward the stimulated side and suck. The Moro or startle reflex. Hold the infant supine, supporting the head, back, and legs. Abruptly lower the entire body about 2 feet. In infants up to 4 to 6 months old, the arms should abduct and extend, hands open, while the legs flex. The infant may cry. Absent primitive reflexes, or retention of those reflexes past the usual age they disappear, may signify abnormalities. General indicators of central nervous system disease during infancy include abnormal localized neurologic findings, asymmetry of movement of the extremities, failure to elicit expected primitive reflexes, late persistence of primitive reflexes, re-emergence of vanished primitive reflexes, delays in reaching any of the following developmental milestones: gross motor, fine motor, cognitive and language, and social and emotional.